Hello, good evening, friends. Today I've come up with the evidence-based critical evaluation of techniques of Caesarean section part 2. Today, let us discuss the other aspects of the Caesarean section techniques. So I hope yesterday you enjoyed the talk. I'm not going to repeat whatever I said yesterday in the interest of time. Let's not waste time and straight away get into the other aspects. What does evidence say about auto suturing technique? Yesterday, I told you I have never used auto suturing technique at all because it has got very little benefit in the sense it reduces the bleeding and especially useful in HIV. However, we have never used it. Let's look at what does evidence suggest. It's a Cochrane review. No difference in amount of blood loss during the procedure. So even if the auto-suturing technique claims that, the evidence doesn't suggest that, statistically significant increase in the duration of the procedure with auto-suture. So it unnecessarily takes away the time. There is no need of that. I don't want to dwell more on this particular issue. So no benefits over conventional sharp dissection. So it's good enough if you are careful without injuring any major vessels. And if you do the blunt dissection, that should be good enough. There is no need to buy this auto suturing machine and get into problems. The next most important step in the cesarean delivery is delivery of the baby itself. We have opened the abdomen in layers. We have opened the peritoneum, the visceral one, push the bladder down. We have opened the uterine, anterior uterine wall also. Now comes the time to deliver the baby. Are there different techniques in this? Yes. Again, there are very many techniques. In another talk of mine, that is the what do you call the troubleshooting of the cesarean complications. I have dealt in detail about the different modes of delivery, but today let me critically evaluate them and show what the evidence suggests. We have the goal of delivering the baby expeditiously and atraumatically. Keeping this in mind, the studies have reported a direct association between a prolonged uterine incision to delivery time and lower fetal blood gas pH values and Apgar scores, regardless of type of the anesthesia, whether you give general anesthesia or you give spinal anesthesia or you give epidural anesthesia. What it means is that after the uterine incision, you have to immediately deliver the baby. You should not spend much time in delivering the baby. That's exactly why you must give an adequate incision on the uterine wall, and you should have adequate knowledge about different types of delivery of the baby. What if the baby's head is mobile? What if the baby's head is deeply engaged? What if the baby is presenting as breech or transverse, whether with the back superior, back inferior, and if it is a conjoined twins, if it's a big baby. So all these things we should have understood beforehand, because there's hardly any time after the incision. The sooner you deliver the baby, it is better for the baby, else the baby will have low pH values and Apgar scores. So what are the methods? If it is a fixed head, that's the easiest and the best to have. You have to just lever out the head without causing much trauma to the neck of the baby, or it can also be called hook out the head. When I was having, when I was taking exams, DNB exams with my co-examiners, one of them asked, what is the role of the thumb? None of the students could answer. You never thought of it. The answer is very simple. There is no role for the thumb in the delivery. You don't grab the baby's head. You just use, as you can see here, you just lever out the baby's head. The thumb doesn't do anything. So don't ever try to catch the baby's head or anything like that. You will use the thumb only when you are trying to deliver the baby in a transverse line by catching hold of the ankles of the baby, do internal podalic version, then do the breech extraction. But in delivering the head, the thumb doesn't have any role. What if it is the mobile head? This is the most difficult actually presentation for delivery of the head. What you can do, you can start with the simple technique of putting your hand beneath the baby's head and then drain the liquor out. As you drain the liquor out, the head will slide on your palm, and then you ask the assistant or the anesthetist usually come in to help at this time. Then also you will lever out the head. So this is the simple technique of delivering the mobile head. But if this doesn't help, then many people, many obstetricians, they do it routinely, what is called forceps delivery or a vacuum delivery. Here, you remember, we have to use both the blades of the forceps. And this will be cephalic application, not pelvic application. The blades should go onto the either side of the baby's head, as you can see there. First, of course, you insert the lower blade, and then you insert the upper blade, and then you lock it, and of course, deliver in the same fashion as we lever out the head. Suppose you are not confident about forceps delivery, you can use a vacuum also to deliver. Here, the placement of the vacuum cup is as posterior as possible. We can apply the same rules as in vaginal delivery. You should have a longer tubing, of course, and it should be always kept ready in the OT. And then you have to facilitate the flexion of the head as you deliver the baby. Always, whether it is hand delivery or the forceps delivery or the vacuum delivery, you should facilitate the flexion of the baby's head. That is exactly why before you go for section, it is always advisable to find out which side is the back of the baby, which side is the occiput of the baby. So of course, occiput and back are on the same side of the baby. So if it is the left occiput anterior, usually we are standing on the right side of the baby. You deliver the baby towards you. If it is, on the other hand, right occipito anterior or posterior, and you are standing on the right side of the baby, you should take this way and deliver away from you. Whatever it is, one simple thing you have to remember is always make sure that the delivery of the head is by flexion of the head. Don't extend the head. Then if you extend the head, it will be very difficult to deliver that baby. So whether you are delivering by the hand or by the forceps or by the vacuum, you have to facilitate the flexion of the baby. What if it is a deeply engaged head? So here we use vectis. Vectis is a special instrument. It's a single blade. Suppose you do not have vectis in your hospital, you can use the single blade of the forceps, outlet forceps. That single blade can be right or left, doesn't matter, because you just use it like a shoe horn. You insert the blade between the uterine wall and the baby's head. You have to be very careful. If you are not careful, I have seen some of the obstetricians putting that blade all through and through the bladder. So you have to be very, very careful. You should remember that the bladder is sitting right on top of the lower segment of the uterus. Very careful. The vectis blade should, it should be snugly going onto the head of the baby. So don't put it this way. If you put it this way, it will go into the bladder. So it will go onto the baby's head and deliver. In fact, when the head is deeply engaged, it will jam actually, and you have to break the vacuum there. I'm not saying you use the vacuum. I'm saying the vacuum that is created between the pelvis and the baby's head. So if you can insert your finger, if you don't have vectis or forceps in the OT, that is welcome. But only thing is, my fingers are so thick. Ladies' fingers may be very thin, so you can insert nicely. So when you insert the fingers between the head and the uterine wall or the vectis or the single blade, a sound will come, the gushing of the air from below that. When the sound comes, your delivery will be very successful. Suppose you cannot go as low as the head. You can ask your assistant to wear a gloves and push the baby a little bit. And when the person is pushing, make sure that he facilitates flexion again. He should push more at the occiput rather than at the center of the head. If he pushes at the center of the, it's not the way to just push the baby's head. He is actually trying to flex the baby's head. So he should push from here, this part of the baby's head, so that he won't cause damage to the anterior fontanelle. Suppose this method does not work out, then Patwardhan's method. There are again 4 different techniques in Patwardhan's method. In this particular lecture, I'm not going to explain that. I have explained it in another lecture where I'm talking about the troubleshooting of the Caesarean section. Breach, of course, if it is breach, there is nothing to worry. You can deliver as you do it in case of assisted vaginal delivery. That means, of course, you deliver step by step, deliver the legs will come off easily. Then you use a breech towel, rotate the baby using the femoropelvic grip in such a way that the back faces the obstetrician. The only difference between the assisted vaginal breech delivery and the Caesarean breech delivery is that in assisted vaginal breech delivery, you don't pull. Here you have to pull because the patient is under anesthesia. But while pulling also, there is a technique. You should pull parallel to the table. You should not pull upwards. If you pull upwards, what happens? Then this head will become like extended head. So when the head gets extension, it will be very difficult. So when you pull parallelly, and then of course you have to make arc of a circle on the baby's mother's uterus or the tummy, and the delivery is completed like a Burn Marshall technique. So that is the way we can deliver even at Caesarean delivery. If it is transverse line, beforehand itself, you should know whether it is a back upwards or back inferior, and then whether the legs are on the right or left, because the technique is very simple. You have to put your hand inside the uterus towards the feet of the baby, catch hold of the feet, and then do the internal podalic version, and then finally breech extraction. So these are the different methods of delivery of the baby, right? So evidence does not say much. It simply says that you use the appropriate technique to deliver the baby. Nobody has done any randomized control studies on different techniques in a different given presentations. So let us now go to the delivery of the placenta. That is the next step. So what are the methods of delivery of the placenta? Of course, placental drainage with spontaneous delivery. So we usually do not allow this to happen because that may be sometimes very time consuming and late, and patient is on anesthesia and things like that. What we usually go for is a controlled contraction. Many obstetricians are tempted because you have opened the uterus. They are tempted to put their hand inside and catch hold of the placenta and remove. That should be avoided. As far as possible, intrauterine manipulations should be avoided. What you can do instead, if you want, the controlled contraction, you can also push the fundus above as you did in case of a vaginal delivery. If at all, you can put just 2 fingers inside the uterus through that incision and hold the cord and do the controlled contraction. This control is to prevent the fundus from doing inversion. So either you can push the uterus upwards just like that, or can put 2 fingers inside the uterine cavity. So this is the best method, controlled contraction. Of course, as I said, some people, they have the habit, even if the uterus, even if the placenta is normal, it is not adherent, they would just put their hand inside and catch hold of the placenta itself and do, which will be called manual removal of placenta. In certain situations, you may have to do this deliberately. For example, if it's an adherent placenta, or if it is placenta previa, which is going for accreta, and especially, the central placenta previa, things like that, you may have to literally remove the placenta. It may not come off easily because in the lower segment, Nitabuck's membrane is absent, and so placenta is stuck with the uterine wall. You may have to remove the placenta manually. The other technique after the delivery of the placenta is that before we separate the baby, delayed cord clamping. Usually 30 to 60 seconds is what is advised, ideally following the onset of respiration. I wouldn't say this is a now new thing. It's been there for the last 4 or 5 years already. Earlier, we thought if there is a preterm baby, extra blood is not welcome because that will cause jaundice. Now we realize jaundice is not a big problem. The bigger problem is intraventricular hemorrhage. So to avoid intraventricular hemorrhage, it is better some extra blood is there with the baby. So that would prevent, also it would prevent the anemia in the baby. So The jaundice part will be easily taken care of by either phototherapy or just by waiting. It will all go once all the bilirubin is cleared by the liver, even though it is a premature liver. So delayed cord clamping is here to stay. Even in term babies, it is always better to delay the clamping by 60 seconds or at least 1 minute. So what does the evidence say about cord traction versus manual removal of the placenta at caesarean section? Cord traction has the following advantages: less blood loss, less decrease in hematocrit postoperatively, less endometritis postoperatively. So anything introduction of your hand into the uterus will definitely introduce infection, though initially you would have taken care of all aseptic precautions at the time of surgery. When you have handed over the baby to the nurse or things like that, there will be some contamination, and that contamination will get into the uterus, so endometritis will happen. So if you do cord traction, that can be avoided. Shorter duration of hospital stay. Obviously, when there is no infection postoperatively, the duration of stay will be shorter. So it is always better to do cord traction, controlled cord traction. What about changing the gloves after placental delivery? Like, changing the scalpel blade yesterday I was talking about. Some people have the habit of, changing the gloves after the delivery of placenta. Nowadays, anyway, all of us are using double gloves. So what they do is they change the upper gloves. Inner gloves will always be there, and they wear fresh gloves. Let's see what does the evidence say about it. Change the gloves after placenta delivery reduces wound infection by 60%. As I said, when you have delivered the baby, you are handing over the baby to the nurse, though the nurse is holding a sterile towel, all those things. Inadvertently, you would have touched here and there. That's why the habit of changing the gloves after the placental delivery when you try to complete rest of the cesarean section. However, the intervention did not reduce the frequency of postpartum endometritis or febrile morbidity. So I leave it to you whether you want to change the gloves and charge it on the patient, or whether you want to just remove the upper gloves and manage with the remaining gloves. The double gloves is basically to protect ourselves from any needle stick injuries or things like that. But then, you have to look at the bigger picture and take a decision. Many limitations in the trials included. So that's why we cannot, I am not emphasizing much on this particular aspect anymore. What about wiping the endometrial cavity? See, this is one of my teachers used to talk about this. He would take a mop at the end of the placental delivery, and he would put nicely wipe the endometrial cavity. The reason he used to give is that anything small, membranes, other placental tissues, bits and are remaining, they will come off with the mop. Whether it should be done or not done, it's a recent evidence, 2019 evidence. This is to, as I said, ensure that the entire placenta and any remaining membranes or placental tissues are removed. This maneuver may also stimulate uterine contraction, according to some. But omission of intrauterine cleaning had no significant effect on the frequency of any intraoperative or postoperative complications. Thus, this step could possibly be omitted. You see, as I said yesterday, hundreds of techniques are there, and cesarean section is one thing which thousands and thousands. It's the highest. It's the number wise. It's the highest surgeries that is done in the world. Cesarean section is number one surgery all over the world, including all specialties, I can say. So that's why there are so many techniques. Each one develops his own small technique. And the beauty is that people have done randomized controlled trials of each technique. And today we are so much wiser about all these things. So what I would say about this is there is no need to wipe the endometrial cavity. In fact, whatever you do, these extra things will always harm the patient. That can even cause sometimes, adhesions, intrauterine adhesions that can cause secondary infertility. that can cause endometritis and things like that. Don't do anything extra. Any bits or pieces are remaining, they will all come out in the lochia rubra, or even later. So body has a mechanism to get rid of unwanted things. Only if the patient develops a real problem later, maybe we can do an ultrasound in the postnatal period and see if you have really left behind any major chunk. The possibility in a cesarean section is very, very low. Now, this is the biggest controversy once happened when I was junior staff. One of the teachers was always teaching that you should always mechanically dilate the cervix, and I was assisting one of the PGs, and in fact, the PG had done it, but some other PG told that it was not done in that particular case which I was assisting. And that particular teacher made a big issue out of it, and there was a lot of commotion in the department with regard to this. So I was always curious to know whether this step is, because I didn't personally believe in that. See, in gynec uterus, there is a pinhole os, yet the menstrual blood comes out of it, isn't it? Even the clots come out of it. So here, at least in a pregnant uterus, patulous os, definitely whatever is there in the uterine cavity, the blood or lochia, it won't remain there just because you have not dilated the cervix. It will come out. Anyway, I don't want to give my personal opinion about it. Let's see what Cochrane review has told about this. I'm very, very happy today that finally what I believed in, 1988, 89, or maybe later, early 90s, is been proven now in 2018 by Cochrane review that routine manual or instrumental cervical dilatation before closing the uterus is unnecessary. I'm so happy to read this sentence. In both laboring and non-laboring patients, the logic was, if the patient was laboring, some amount of dilatation would have occurred, so there is no need to dilate the cervix. But in a non-laboring patient, elective cesarean sections, you have to dilate from above. I was not somehow convinced with that, because any unnecessary intervention should be avoided. That's the basic principle of surgery. So it is very, very clear today, not less than Cochrane review. Usually Cochrane reviews don't come out with such clear conclusions. Here they are very, very clear that routine manual or instrumental cervical dilatation before closing the uterus is unnecessary in both laboring and non-laboring patients. Further, meta-analysis of randomized trials have found that this practice does not reduce post-operative morbidity. Another Cochrane review. And I do not mechanically dilate cervix before uterine closure in any cesarean birth, including those with a closed cervix, to avoid injury. Okay, let's move on to the next point. See, as I was telling, so many things people have been practicing doing, but the beauty of it again is Cochrane has pointed out all these small techniques, and they have done a randomized check or a systematic review, and they have given us very clear-cut, guidelines. Uterine irrigation. So people just wanted to not only mop the uterine cavity, they wanted to irrigate the uterine cavity clean. There is no strong evidence that uterine irrigation with an antibiotic solution, see, people have thought of not just saline, but they have put antibiotic in that, so that they think that they can prevent, is more effective or advantageous compared with pre-incision parenteral antibiotic prophylaxis. See, that is why just before the incision, you have to give the intravenous or parenteral antibiotics prophylaxis. So that will cover the time of our incision as well as during the closure. And that is good enough. There is no need to again further do the uterine irrigation. That is been very clearly mentioned in this particular Cochrane review. I do not irrigate the uterus before closure for prevention of post-operative infections anyway. What about the uterine massage to prevent the PPH? Uterus is there in front of you and you feel like holding it and massaging it and things like that to prevent the post-operative bleeding. No randomized trials have evaluated the efficacy of massage after cesarean birth. That's the first thing. But when you have given this, what is called active management of third stage of labor in vaginal delivery, same thing can be applied here. Oxytocin 10 units IV or IM. Usually, anesthetists, they do not understand clearly unless we tell them clearly. What they do is they'll push 10 units in the IV drip. If they push IV drip, it will come very slowly over 5 hours, isn't it? Usually we give 100 ml per hour. So it will be delivered over 5 hours. So that is not to be done. This is a prophylactic one. It has to be better given IM, or you can give slow IV straight away. If they want additional 10 units can be added to the drip. So it has to be very clearly told to the anesthetist. Otherwise, they usually push it into the bottle itself because that's easier for them to do. Or you can give misoprostol 600 micrograms per rectal or tranexamic acid 1 gram IV may be administered after the delivery. This is better than just uterine massage. Of course, if in spite of this, if the uterus is bleeding, then of course uterus is there, you can massage it. Some people even have the habit of giving uterine or intramuscular of the uterine musculature injection of oxytocin. All these things are actually can be avoided. The next issue is now the baby is being born. What should be done with the baby? Care of the newborn, and appropriately trained pediatrician should be present to care of the newborn. Usually in a hospital like Manipal and any tertiary care level hospital, we have the luxury of having a neonatologist, if not at least a PG posted neonatologist to take care of the babies after cesarean. Caesarean babies usually have a slightly higher incidence of RDS compared to the vaginal deliveries, in spite of there being no other complications in the mother. So a pediatrician should always be there, if not a neonatologist. Early skin-to-skin contact between mother and newborn appears to promote breastfeeding and may help with physiological stabilization. In fact, now in Manipal, our neonatologist insists that as soon as the delivery, before cutting the cord also in vaginal deliveries, they put the baby on the mother's chest and they'll ask the mother to feed the baby. Even in after cesarean section also, because we are doing mostly under spinal anesthesia, mothers are awake and they put the baby on the mother's chest and they ask the mother to feed. Two things happen. One is, of course, the bonding and other things, and breastfeeding is facilitated. When the baby sucks the nipples, oxytocin is released naturally by the mother, and that would help in the uterine contraction and expulsion of the placenta, and then prevention of the postpartum hemorrhage. So there are multiple benefits by doing this particular thing. It has become almost routine in Manipal. I think that's a good practice. So I now come to the closure of the uterine wall. Having delivered the baby and placenta, we have to now go for the uterine wall closure. So here again, let me discuss the methods of uterine closure. Usually, people have the habit of exteriorizing the uterus outside, so they feel that it is very easy. They put a hand inside and get the above the fundus and get the uterus outside, and uterus is standing on the in front of you, and you can easily suture. This is a habit for many people. This has its advantage. The one is advantage is just the visibility. Disadvantages, sometimes suddenly patient can have vagal stimulation with these procedures, unnecessary infections and things like that. You can simply push the fundus slightly above when within the abdominal cavity itself, so that the incision area comes very clear to you to suture. There is no need to exteriorize the uterus. I hardly do that. Some people do it to prevent the bleeding. Once there is a lot of bleeding, then they put hand behind the uterus and then they try to come out and they'll kink the uterus. All sorts of things are done. But I personally prefer to just push the uterus within the abdomen itself slightly above, ask the assistant to do that, so that the incision comes into your field of vision and you can do a good closure of the uterine wall. The other thing is, single layer or double layer, right? Obviously, I prefer double layer because it comes out beautifully. In the first instance, you take only half thickness of the uterine wall. And in the second instance, you take the full thickness, excluding the first line. So it will be beautifully one above the other. And that would be very nice. It's like a double bracing of the uterine wall, especially if you are planning to have one more pregnancy. In primigravida cesarean sections, it is always better to put double layer. In multigravida, if it's a repeat cesarean section, if you are not planning to have one more child, and if you are doing concurrent sterilization tubal ligation, then probably single layer is good enough, because that would save some time. At least 3-4 minutes or 5 minutes time will be saved. If you are in a hurry to finish the cesarean section fast, that's the only reason why you can do single layer. Otherwise, double layer is always better, welcome. You have to secure the corners and you have to secure all the bleeders. Sometimes you may have to put in between the transverse sutures in order to, or the vertical sutures to prevent the bleeding, depending upon which artery is bleeding and where. Interrupted sutures or continuous sutures is always, and in continuous sutures, whether continuous locking and unlocking. So there are many techniques. And then we can have another talk on the suture material also. Anyway, I'm going to talk about it in the subsequent slides. Now, interrupted sutures sometimes are better because the argument is that if one suture is infected, it will not totally break down the whole sutures. That is the argument. But then if infection is there in one suture, the other suture is very adjacent to it, infection can go there also. Continuous suture is easier, obviously. It can be very quick. You can continuously do. Otherwise, you put one suture, cut it, and again take another bite. And continuous suture, should it be locked? There is no need to lock. Usually what we do is the corners, first 1 or 2 bites we may lock at the corner, and the rest of it will go continuously. And towards the end, we may lock again 1 or 2 sutures. In between, if there is a bleeder, then we may lock it. Because what happens if you lock, that area becomes actually avascular. Right now, during the surgery, you may feel that I have controlled the bleeding, but it becomes avascular. Even when you do continuous, ask your assistant not to hold it very tight. He has to just hold it to approximate the edges. See, the idea, whether it is uterine wall, whether it is rectus sheath, whether it is skin, idea is to bring them together. You cannot heal by suturing. It's not like suturing the shirt and things like that to make it watertight. Suturing is just to approximate the 2 edges. Healing is done by nature. It is not done by doctors. Doctors suture, and if they think that you are suturing and healing, it is totally wrong. You are approximating the cut edges and facilitating the natural process of healing. So let us look at each of these techniques evidence-wise. What does evidence say about extra versus intra-abdominal uterine closure? Whether you should always exteriorize the uterus. Extra means exteriorizing the uterus or not. It has got its own disadvantages. Not enough evidence to say if closing uterine incision is better done within the abdomen or outside. Okay, this is like, again, typical Cochrane style. They usually don't give very clear guidelines. Very few situations they give very clear. They finally say not enough evidence. So here again, another situation where they say not enough evidence. Both personal preference and individual clinical circumstances should guide this decision. What do you mean by individual clinical circumstances? As I said, suppose there is a lot of bleeding. You would like to put your hand behind and make the uterine artery taut so that the bleeding stops temporarily, so that you can take some bites, and once the bleeding is arrested, you can leave that. By exteriorizing the uterus also, you are kinking the uterine artery, so the bleeding stops sometimes. So that is the meaning of clinical circumstances. Personal preference, of course, it's your habit. What you have seen your seniors do, your teachers do, you may continue with the same habit. Habits die hard. That's what we say, whether good or bad habit. So you can continue. There is nothing preventing. And in fact, this is a very recent, reference, 2022 February. Other one is 2021 November. So all are saying that you do whatever you have been doing. What about inclusion or exclusion of endometrium during uterine closure? This has been a very big debate once in Manipal. Some people said you should include, some people said you should not include, and the evidence is again here, very recent evidence, 2022 and 2021. Let's see. Data support excluding the endometrial layer to prevent niche formation. See, this niche, if you recall, I talked about this in the abnormal uterine bleeding class. Niche is something like one, area which can be easily seen as like a, echo-free area in the ultrasound. And that will be the cause of abnormal uterine bleeding. That will be the cause of abnormal discharge and so many other things. In an obstetric situation, in the next pregnancy, this will be the weakest area, and that will go for a rupture uterus. So niches increase the risk of postmenstrual spotting, dysmenorrhea, dehiscence, rupture, placenta accreta spectrum, and scar pregnancy. So don't include the endometrium. So always better to just suture the uterine wall, excluding the endometrium. So that is the clear-cut evidence. What about blunt versus sharp needle? Again, this is also another thing that we debate, whether to use a sharp needle or blunt needle. Use of blunt or round tip needles during closure is associated with similar maternal outcomes as use of sharp tapered needles, and is much safer for surgeon, especially with regards to glove perforation. So blunt tip is better. Don't go for the sharp tip. There's no need actually. Sharp tip may be needed for rectus sheath, which is tougher than the supple uterine wall. What about, again, single layer and double layer? I already gave out my opinion. I always prefer double layer in primary gravida, especially when she wants to have one more child because of the fear of rupture in the subsequent pregnancies. Let's see the differences. Less operating time, single obviously, and less tissue disruption and less introduction of foreign suture material. So all are good, it looks like. But double layer is better hemostasis and better wound healing and possibly reduce risk of uterine rupture in subsequent pregnancy. So here I'm not saying this is better, that is better. So each one has got its own advantages. You look at them carefully and decide what exactly you want. As I said, it is very, very obvious. If you are anticipating one more pregnancy, go for double layer. If you are having any bleeding at that time, go for double layer. And of course, if it is second time, third time, if you are concurrently doing the sterilization, you can go for single layer. So let's see what evidence say. Single layer was associated with a reduction in blood loss, 70 mm, duration of procedure by 7 minutes, postoperative pain and length of the hospital stay. However, no clear differences for heavy blood loss, fever, or wound infection with regard to single. And about double and single layer closure associated with 4-fold increase in the risk of uterine rupture, as I said. So don't do it in the primary gravida. Compared with the unlocked suture, locked suture has been associated with higher occurrence of surrogate markers of scar weakness and dehiscence and rupture. That is because when you do locking, there will be avascularity and that area will become weak, and that will be the area which will go for dehiscence. So there is no need to lock every single bite. Only the corners, as I said, or if there is a bleeder in between, you can lock. Otherwise, continuous suturing is always better than the locked sutures. I think I will stop after this slide. Single layer may be used when concurrent tubal ligation is performed.